computer. Great. So today we're really excited for our final seminar of this academic year to have Colijn with us. Colijn works at the interface of mathematics, evolution, infection, and public health. Most of us, or a lot of us Canadians on this call, will know her well. She joined SFU's mathematics department in 2018 as a Canada 150 research chair in mathematics for infection, evolution, and public health. She did her PhD at the University of Waterloo, and then worked with Michael Mackey, who's on this call, at McGill, and then was in Megan Murray's group at the Harvard School of Public Health and the Broad Institute at MIT. And then she moved to the Department of Engineering Mathematics in Bristol, England, and joined Imperial College London, Department of Mathematics in 2011. She's brought interests in applications of mathematics to questions in evolution and public health, and was a founding member of Imperial Center for the Mathematics of Precision Healthcare. So we're very excited to have Colijn with us today to talk about vaccine deployment in Canada and what we're doing well and what perhaps we're not doing well. And I think that this will be a great cap off to this series this year. So without any further ado, as usual, please write questions in the chat during, and then if you want, people can ask during, but then we'll have a period at the end for questions. So thanks.
Okay, thank you so much for the warm introduction. Great to see those of you I know, and look forward to one day meeting those of you I don't know. If you have questions, I won't see the chat because I'll share screen and it's awkward to kind of take a look. So people do feel free, if there's something clarifying or burning, feel free to just interrupt, and it's always more fun when it's a bit conversational. Okay. So hopefully you see this okay. All right, good. I want to talk about modeling and policy in the pandemic and some work we've been doing. I'll talk about a few different models based on work we've been doing since the very start of the pandemic over a year ago, when we organized a hackathon to kind of jump into some of the data that were emerging that infectious disease modelers were looking at. And I want to highlight Sean Anderson, who wrote, he's a brilliant statistical ecologist at the Department of Fisheries and Oceans, and he wrote the R package that's behind these nice pictures that you've seen, and colleagues Paul Tupper and my group of researchers, that this is really joint work, and it's been a team effort throughout the pandemic. Okay, remember flattening the curve? That went around was kind of a phrase that, a general public who had not heard of infectious disease modeling and SIR models and curves, every conversation you had would have somebody doing this in it. It really takes you back, doesn't it? Okay, so we built a simple model that had, some of the population engaged in social distancing. This was last March. And others not able or willing to participate in distancing who kind of had full contact. I'll tell you a bit more about that model. We wrote, it was simple, and it made these curves that go like this. They go up, they go down, just like an SIR model, if you're familiar with that. And this was the time of the kind of flattening the curve. So we wanted to illustrate what that model would look like. It actually, I was surprised. It's such a simple model, but it really looked the same as the really complicated Imperial College London model that had 9,000 lines of undocumented C code or whatever it was, that full agent-based, simulating the houses and the schools and the buses and the trains and the towns and the highways and the ages and the social contacts. This is a much simpler model, but of course, these things have a certain similarity to them. It caught the attention of a guy, Ivan Semenuk, at the Globe, and we put out this article that we jointly wrote in the Globe just to illustrate what is social distancing and what's flattening the curve. And we had this, don't do anything, do something medium, and do something strong. But I wanted to just highlight this now because of the importance of putting your models and your data in context, or contextualizing, which is a word I use kind of with a sense of irony, but recognizing how important it is. So our strong intervention here ended up at a peak of about 8,000, of about 7% to 8% of the population infected at the same time. So what would that look like in BC? That's about 400,000 people. or if you're in Ontario, 120 to 180,000 daily sort of prevalent infections. So you would multiply this by about 1.5 to get Quebec, maybe a little more. So you'd have 600,000 simultaneous cases. That would be an incidence, a daily case count in the tens of thousands. So for BC, 40 to 60,000 daily cases. For Quebec, 1.5 times that, so maybe 60 to 90,000 daily cases. We are not there. We have never been there. We didn't flatten these curves and let them kind of run out and have a first wave. What we did was we crushed them and kept them all the way down at the very bottom with under 1% of our population infectious at a time. Okay, so flattening the curve is not really what happened. The hospitalization rates were high enough that we couldn't do this without overwhelming our hospital system. And we're still stuck there. We're stuck at the beginning of one of these things. All right, here's our little model. So we have susceptible, exposed, and infectious, but not yet feeling sick, and infectious and symptomatic. And then you can go home and isolate in your bedroom or some other quarantine or recover. Dynamically, these are the same. It doesn't make any difference. The interesting thing about this model is that we have a kind of layer of people who are unable or unwilling to do social distancing, and a layer of the majority of the population who are able and willing to do social distancing. So the people who are distancing, they're less likely to go out and contact others. And when they do go out, the people they bump into are less likely to be other distancers, because those other distancers are all sitting at home giving talks on their laptops. Okay, so we have some fraction of people who are willing and able to distance, and that's set by the rates. You can leave and enter these. You can take up a job as a healthcare worker and lose your ability to work from home, or you can quit your job as a warehouse stacker and gain the ability to work from home. However, the dynamically important thing is we have this fraction F by which the distancers reduce their net amount of contact. And that F comes up twice because of the first two bullet points. They're less likely to go out and contact others. And when they go out, they contribute less to the force of infection. So they're less likely to bump into other distancers. And this little model actually does all the things that you love and need a simple model of social distancing to do. Well, maybe not all of them. If you like, you can roll out your classic math biology tools, and you can do stability analysis in the model, and you can show that, of course, if transmission is high enough, you get disease, and if it's low enough, you get a stable disease-free equilibrium, and that's great. This is a heat map showing the fraction, the relative contact rate for the distancers, and this is the fraction of the population in the distancing group who are willing and able to distance, and these lines show constant contours where R is 1. So what we did early on in the pandemic was use this model to do estimation and figure out where was F, and estimated a bunch of other stuff. And here in March last year, or I guess in early April last year, but a year ago, we were really well below where we needed to be in BC for kind of crossing that threshold. So we had some leeway there. All right, so that's what you'd expect this model to do. Of course, you can do it. The estimation, I think, is maybe more interesting. So we were at the time very frustrated about testing because, of course, testing has never been a uniform random sample of the population. At the time, that kind of made sense because testing resources were really low and they wanted to find the cases. They were using testing to find active cases. So screening the whole general population was not a useful, well, it wasn't an effective use of testing. But for modelers, if you want to know the virus prevalence or incidence, you don't want testing that's like symptomatic healthcare workers one week, but symptomatic healthcare workers and travelers the next week. And no, maybe not travelers, because now, okay, wait, no, maybe symptomatic healthcare workers and people coming into hospital. You don't want this. So it was frustrating. So we had to figure out a testing model that would sort of cope with this. So we had some kind of average fraction of people getting tested, a delay between infection and testing, and an over-dispersed kind of case count. So we had, the likelihood of a number of cases per day was given by some negative binomial model that took our deterministic model incidence as a function of the parameters of the model and some dispersion that we also estimated, and said, okay, so that's how we're going to handle testing. I think between then and now, we've kind of gone through the 5 stages and reached acceptance around the testing question, and we're not going to have great like population samples for testing, and we sort of live with it. So we estimate the model parameters, some of them, in particular this contact fraction F, but also, a baseline underlying transmission force or effective reproduction number R, some sampling fraction, and other things. So there are some trade-offs there. Of course, you can't estimate all of the things. Okay, so then we do this estimation. This was early on last year, and we get results, of course, these beautiful figures that match the data well. In fact, when we make them, they're blue, and someone in Bonnie Henry's team would go through them with Microsoft Paint or something and make them pink. I don't know quite why. But these were used in BC in the response to the pandemic, partly to do forecasting and see where case trajectories were likely to go under different decisions, but partly, I think, just as a tool to communicate with the public, to say, okay, everyone, like this contact rate we're doing is really working. We jumped up our testing steeply here, so you get this bump up in cases because they widened testing on April 14th, and you can see about a week later you start seeing people responding to that. So that was great, and it's nice to see Bonnie Henry in front of one of our slides. This was earlier on, of course, when it was sort of late April. Okay, I won't go through the trade-offs. So we do have a paper about this in PLOS Computational Biology if you want to look at kind of what happens if you change the assumption of the sampling rate, and it turns out you get the same distancing estimates. These percent of normal, this F that we estimate, is quite robust, even though there's a lot of other trade-offs around the underlying R and the sampling fraction and the number of cases you start with at the beginning. Of course, if you imagine you really had 25, but you only sampled one of them, you get a slightly different answer in the model. Okay, we then were asked to do these weekly for the Public Health Agency of Canada, which we're still doing now, but now including variants. And this was now about, well, this was probably just a few weeks ago, right? This is this March, we did one of these, and we pull them together. So these are for each province the same thing. Take our distancing model. We introduce these kind of breakpoints with the vertical dashed lines. I'm not sure if you can see my mouse, probably not. Someone can tell me.
We can.
You can see the mouse. Okay, then I will try not to jiggle it everywhere. So these vertical dashed lines where we allow breakpoints, and we inform these by policy changes where we can, because of course, if you don't do that, you can put lots of breakpoints and get the model to look beautifully like the data, but that's really a kind of manual drawing. So we take these from known policy changes that PHAC collects. And then if we really need to, we have kind of a heuristic for adding another breakpoint. And you can see it kind of looks fine. Of course, you can track this thing and you can collect up what the total exposure has been and how close we are to herd immunity. Spoiler, not close at all, despite the fact that we think we have all these waves going through. And then we wrap that up into a national level forecast that every once in a while pops up in Teresa Tam's presentations. This was one where we always have these, what happens if we increase our control measures, or what happens if we, make them stricter or less strict? And of course you get transmission or less transmission, more or less or the same when we make these projections. But sometimes when they're really striking, they catch someone's attention. And that this was the moment when Justin Trudeau started using the crossroads language, and we're at a crossroads, and what are we going to do? That was last fall. Turns out what we did was continue the mitigation up and down strategy. Okay, so now what? We have two things going on right now that are at really the front of my mind in the pandemic. Variants have arrived in force and are challenging our hospitals, challenging our control. And at the same time, vaccination has begun in the kind of general population way. It began in special populations, very targeted vaccination months ago. So what happens next? So variants are arriving in force. This slide is already a couple of weeks, maybe a week or two out of date. So higher transmission variants, especially the B117 variant, which arose in the UK last fall, they have arrived here and they have spread across Canada. If not contained, current measures will not leave R, the effective reproduction number in the absence of vaccine, near 1 anymore. And in fact, that ship has sailed. All of the provinces, I think, are now seeing rises. If R was 1 before in BC, which it was, so sort of through January and February, guess what happens if a variant comes whose transmission is higher? Well, it's bigger than 1. You don't need a sophisticated Bayesian model with a negative binomial testing and blah, 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 blah to know that if something is 1 and then something else comes that is bigger, that new thing will be bigger than 1. In fact, Eric Voltz and colleagues estimated a 40 to 80% increase in transmission for the B117 variant, and that was based on really good data from across the UK. Okay, so if we don't contain this, what happens? Well, transmission, and then we have to do severe shutdowns, which I think we are now seeing. We have moved more towards immediate detection of variants by PCR testing and by whole genome sequencing, but we were not in place to do that in December to prevent this from happening, or in January. We're more in place now to notice how much it has happened, which is good, but prevention would have been better. We could be hopping up and down, prioritizing variants for contact tracing and rapid actions and screening and testing, but I think a lot of these, in hindsight, are things that we could have done throughout the pandemic to stop the pandemic, and we were not willing or able to do them, or thinking it was worth it. So I guess it's not a surprise that we didn't do them for variants of concern. But on the other hand, I think we in the modeling community, I think, probably thought this was a bit obvious, that if the transmission is much higher, it will be much harder to control. And our current measures of shutdowns were very costly, and maybe we weren't going to be in place where we're preventing transmission by having vaccinated 80% of the population by April 1st. These were all known things. Okay, anyway, variants have arrived in force. So what happens with modeling? This is a modeling group and a modeling talk. Well, we can take our model of social distancing, where this is the same model before, but I've shaded it with a blue rectangle to indicate that this was the slightly happier, bluer, pre-variant of concern type of COVID that was predominant. And now we have another kind of pandemic sitting alongside, or maybe now overtaking, the blue pandemic, and that's this red one. So we can use 2 copies of the model. And what we've been doing is fitting the model to the data from the wild type or original COVID, and then imagining what happens if you bring in a higher transmission variant and it has its own copy of this model. And they are not, at the moment, I mean, we're doing this now, but in the current figure I'm about to show you, they are not linked in a sophisticated way, in the sense that the 2 strains are not competing for susceptible hosts. And that's because more than 95% of Canadians are susceptible. And we didn't think that linking the models in that way would change the dynamics particularly. So we have our original model with our fits, and we have this Bayesian estimation of the underlying R and the strength of distancing measures and the sampling dispersion and all of these nice things that we estimate. And then we map all of those posterior estimates into our new strain, except that we say transmissibility is higher by some factor. It's higher than the regular transmission rate by, I think I took a kind of conservative 40%. And then we sample uncertainty in that factor, so 40% plus or minus 10 or 15%, and that gives us even more uncertainty than we got out of our Bayesian fitting from the first model. So fit this model to data from the not VOC, then drop the VOC in and see what happens.
Hey, I've got a quick question, Caroline. Sorry, It's Jesse. Just interrupting you as to show that it can be done. Copying that model, does that mean that actually the I forget if it was F or S, the fraction of people distancing, that differs for the variant versus not, or that stays with?
We maintain that because it's the same population. So right. Everything's the same except the parameter beta, which is the transmission rate per contact per unit time.
Right, okay.
So, and that's actually one of the helpful things about having an F, the parameter that reflects the strength and scale of social distancing, and a different parameter that is the kind of per contact fundamental transmissibility of the pathogen, because it allows us to separate the population into 2, it's very simple kind of contact structure, but it's sort of high contact and lower contact, but it also allows us to distinguish between higher and lower transmission rate of the bug. So viral replication plus aerosolization, etc. Okay, great question. So this is what we find, as you might expect. You drop a higher transmission rate in and you see higher transmission. Check that out. It shouldn't be too surprising. We did this anyway because several people at kind of close to policy asked for it. The Public Health Agency of Canada asked for it, and a colleague, Robert Greenhill, who's based at McGill, some of you probably know, we had put together this Canadian Shield document, and he was trying to convey to policymakers that variants are a big deal, and we were trying to help with that. So we looked at these, and what you find is that if you run everything the same, even at a time, a few weeks ago when we were all in kind of a decline across Canada, that decline wasn't sharp enough to keep a 40% higher VOC in check. So we modeled, projecting forward from now, and then we modeled something we called more proactive, which is like, let's just imagine you can knock back transmission everywhere, but you also have a 10%, VOC specific, jumping up and down and doing better contact tracing and having it faster and testing more and so on. And that, I can't see it because you guys are here. That sort of worked great in Manitoba, where they didn't have much VOC initially. And actually Manitoba maintains it's doing quite well, having introduced interprovincial travel measures. But even if you were a little more proactive, you see that this slows, and actually total case numbers can decline because most of them are not VOCs. And then of course the variants, because they have higher transmission, they catch up. All right. So some VOC forecasting. Here are the other 3 provinces, including BC. And these are, it's always hard to draw. If you cut them off too low, then the ribbons look funny. But if you don't, then you can't see the data. So all of that stuff we had in the summer and fall is just dwarfed compared to what we would see if we didn't take this, keep this in check. I should say right now it's first week of April, and we are about bang on where the red line would have been without our proactive measures. Here in BC, we've closed indoor dining recently and stopped some religious gatherings, but these are, I think, much less severe restrictions than we would need in order to stop B117 from transmitting. So I think we're in for an interesting next few months. Interesting in the sense of the Chinese curse, not in the sense of an interesting talk. Okay, so what can we do about it? Well, let's vaccinate. Vaccination is great. We should try this. This is good. We are trying it. And in particular, I want to talk about our work on who we should vaccinate and how we can get the most effective possible use of scarce vaccines. Okay, so vaccines can work in 2 ways, or they can accomplish 2 things. They can prevent severe disease and hospitalization and death if you get infected. It's great. Even better than that, they can prevent you from getting infected in the first place. And these are 2 very different actions. It's, of course, we all want to not be infected in the first place, but at first we didn't really know, I think, whether vaccines would be able to do that. But new data from both Israel and the UK suggests that there are good transmission blocking effects of the mRNA vaccines and the AstraZeneca vaccine. And if you're curious, here are some links. I think this one is now out in Lancet, and some of these have probably come out. But they do show that those where they've actually measured infection as an outcome have been finding that there are good infection blocking capacities of the vaccines. So that's good. There are also, as you know, chronic outcomes of infection. There's long COVID and COVID complications. So a benefit of preventing infection is preventing these terrible things that can be debilitating. So in our work, we called long COVID, symptoms of COVID lasting longer than 28 days. But there can also be chronic complications. And there's a new paper that just came out in Lancet that looked at actually fairly high rates, double what flu has, and surprisingly high of psychiatric and neurological disorders following COVID infection. And I think they looked at 200,000 British people. So, well, people in Britain. So these are both substantial. And in exploring vaccination as a way to prevent infection and vaccination as a way to prevent serious disease given infection, hospitalization, and death, we wanted to think about the benefits of preventing infection for preventing these things that we have not been counting as much. Long COVID, symptoms lasting long enough to make an economic difference in someone's life, maybe unable to keep their job, and so on, which are harder to count than hospitalizations and deaths, but are nonetheless important. So given that vaccines can prevent infection and that infection is a problem in people who don't necessarily get hospitalized or die, can we say, and we have scarce vaccines, if we could vaccinate everyone tomorrow, the rollout wouldn't be important, wouldn't matter. What is the best rollout of vaccines in the context that is relevant for Canada? So keeping in mind what I said about contextualization, what I said about how we didn't let the curve go through, we never got to 7% of the population infected at a time. In our context, what is the best vaccine rollout? Okay, and I'll start with the story version of the model. And it kind of gives you the punchline. So why is protecting an essential worker ever going to be better than protecting someone who is more at risk of a severe outcome if they get infected? Here's the storyline. Essential workers, as we're defining them, have to have a lot of contact. So these are people who cannot work from home and who cannot avoid social contact at work. It's not about how essential the research I do on my laptop at home by myself is. It's about contact and risk. So suppose that by vaccinating one essential worker, you prevent them infecting several others, because you can prevent infection. And if you prevent infection, you prevent them from transmitting to others. Some of those others might be their people they work with, who are also essential workers, or people they live with in a large household or a multi-generational household. Let's imagine that with vaccinating one essential worker, taking into account these transmission chains, you prevent 20 cases over the next 9 months or 8 months between now and September. If each of those has a 10% chance of infecting an elderly person, that's a big if, but if, let's say if, then you've protected 2 elderly people with 1 vaccination. If protecting elderly people is your only goal, you have actually done better with this, bullet-pointed storyline than if you picked one of the 2 elderly people and vaccinated that one. So you're making a more effective use of your vaccine. Now you've also prevented 20 cases and maybe some long COVID and some workplace outbreaks and some economic disaster, but let's ignore that and say we can manage that. It's the elderly people with the severe outcomes that we are most prioritizing here. And even if we're most prioritizing them, you do better with an indirect effect than with a direct effect. Okay, so here's the model version. We have one of the huge, unwieldy, and somewhat inelegant ODEs that I have spoken out against in the past. And those of you who know me will have heard maybe me saying things like, why would people use the 200 component ODE models? Anyway, here's one, and we used it. It's now out in Science, the original one by Kate Bubar and colleagues, including Mark Lipsitch and Jonathan Grad at Harvard. It is a deterministic ordinary differential equation model, and it has age, which means it has all of these boxes or little circles for age groups. It has vaccination. You can be vaccinated or unvaccinated or protected from severe outcomes, but still potentially infectious. It has contact patterns estimated from demographic data based on homeschool work and other same methods that PHAC uses by this Prem et al. Paper in 2016. But it also has this essential worker layer, which is kind of like our non-distancers in the original model. We used some survey data to figure out percents of different age groups that say they cannot work from home, have to work, and have to have high contact at work. And then we figured out a way to get this contact matrix into kind of essential and non-essential workers. And then we model social distancing. We remove workplace contacts for the people who are not saying that they have to have contact at work. And we scale back all the other sort of social contacts. Schools, for example, are operating at reduced capacity, especially high schools, and so on. All right, so we have our usual force of infection term. There's an age-specific susceptibility. There's a contact matrix of how many contacts are there between group I and J. And then we have the infectious folks from age group J, and so the portion of age group J that is infectious. And that all gets wrapped up into a huge system of ODEs that's layered by age and contact. Okay, and the red arrows here are contributions to the force of infection. These folks here, they're vaccinated, but they still get exposed or infectious or recovered. They may be exposed before they get vaccinated, but they still take up a dose. And so when you look at doses, then you need to factor them in. Okay, here's the result of the contact survey for BC. We didn't model any kids in the essential workers, although there's probably some 18-year-olds in there. Those over 80 were very unlikely to be essential workers. There were some in the 70s age group, and then the majority in the rest of the working age groups. Here's a visual illustration of the contact matrix, illustrating that essential workers do have higher rates of contact. I wouldn't worry about the numbers here particularly, because those all get scaled up and down when we, in some way, when we change the underlying kind of transmission to fit the model to data. Okay, but that shows you, kids like to have contact with other kids, and people often have contacts within their own age group. And then within the working population, you have a broader set of contacts, and you usually have these parent to child bars that pop up in these kinds of systems. Okay, we looked at outcomes. We looked at infections and hospitalizations and deaths and long COVID, and we looked at wrapping those up in health economic quantities like these quality adjusted life years and net monetary benefit. I'm not going to talk too much about that. That's a way of avoiding having to have kind of conversations with yourself and others about whether you care more about hospitalizations versus deaths versus infections versus long COVID, to say what's an overall measure that captures those. Okay, here's the model against data from BC. This shows incidence in BC in the fall, split up by age groups. Those are the dots, and the model are the lines in it. We didn't really do sophisticated fitting here. We didn't roll out our Bayesian estimation. We kind of just used the contact matrix and tweaked it a little bit. So I would not report on, hey, we estimated the contact between age group I and age group J as this much compared to the other. We didn't really estimate those. We just sort of fussed with the diagonals until it worked, because it was already pretty good the way it was. And then we looked at hospitalization and death rates that we estimated from a line list in BC. And then before going public with it, we got it again from public data, but they were very, very similar. And we looked at just binning the total hospitalizations and deaths by age. And you can see that the model's not perfect, but it's also, given that we are changing our contact patterns day by day, I wouldn't sort of insist that this had to be fitted to data in a hugely specific way in order to capture, it's not out by a factor of 5 in any age group, or even a factor of 2. We also have a really similar model for Ontario. We didn't need to adjust the contact matrix much, and it looked very similar. That's because it's based on Canadian demographics, and Canadian demographics have a lot of Ontario and Quebec in them. Yeah, but this is the validation for BC. Okay, and then what do we do with now we have our model. Maybe I've convinced you it looks like data. It's got ages, it's got age-specific hospitalization risk, it's got all the whistles and bells and songs and dances. So what we do is we start from January 1st, and for 60 days, we vaccinate those over 80. We recognize we also vaccinate long-term care and a small number of healthcare workers and some Indigenous communities and so on. During that time, we do social distancing. This is what we did do in January and February across the country. And then after that, in March and April, there's a rise in transmission, maybe because of variants, or maybe because we reopened, whoops. Or maybe we got sick of COVID and stopped complying with public health measures. Okay, so we were doing this work, I think, in early March or February. Now some of these things, we could pick and choose which ones of them happened. Then for the next 200 days until September, we follow some vaccination strategy. And Nicola Mulberry, who's a superbly talented student in our group, coded this really nice, flexible, you can put your groups together and do them all together, or you can separate them out by age, and you can put the essential workers in early or later in the program. And this was initially requested by BC-CDC to look at an age rollout to see what happens if we do the 50s and 60s and 70s all together versus the 70s and then the 60s and then the 50s, or what happens if so we have the various options you can choose. Okay, and then some of those options are illustrated here. This is kind of the, this figure kind of gives you an intuition for the main result. I'll just take you through the schedules. So this is your familiar age-based rollout, and you can see the age groups are in colors, and we start with those over 80 in January and February, and then as time goes on, we ramp up vaccination of the rest of the age groups. And so if you're in your 20s, you don't get your dose until July in this original rollout. Or we can say 80s and then everybody else all together. Or we can say 80s and then essential workers, that's this little bump here up to about 10 to 15% of the population, and then continue with the age-based rollout. And it doesn't actually delay things that much. So if you're blue here, then you are age 50 to 59, and your age group is finished directly on the line between April and July. And here your age group is finished just before the line between April and July. So you've been delayed maybe 2 or 3 weeks, not a long time. And then we can go 80 plus, and then all the essential workers, and then everyone all together. Okay, so we explore these different age rollouts, and we make these lovely filled plots where the outcome is shown on the y-axis, and the fill gives you which age group is experiencing that outcome. And we have incidents, hospitalizations, deaths, and long COVID. And this figure just compares oldest first versus oldest and then everyone. So the first two A and B panels. And you can see that if you get younger people sooner, you knock back the infections a lot, but you actually have a slightly worse hospitalization just because younger people have such a lower rate of severe outcomes. And the folks in their 70s suffer a bit of a cost. Their blob here in hospitalizations is bigger, and the same is mirrored in deaths. But if you take essential workers and put them early in the program, so you go 80s and then essential workers, that's strategy C, you knock infections back hugely, and you also reduce hospitalizations, and you also reduce deaths, and you also reduce long COVID. So you don't see this trade-off anymore because you've actually prevented so much infection, and you've got to the 70s early enough that you can not suffer that trade-off. That's basically the story. Vaccinating essential workers earlier in this model and other models is better. This is a slightly complicated plot with lots of rollouts if you're curious about all these differences and details between the rollouts. But to me, the important thing here is the green bar, oldest to youngest, and the purple bar, oldest, then essential workers, then the rest of oldest to youngest. And consistently, the green bar on the left has a worse outcome than the purple bar here. The details of differences between, say, purple and light green, the 80s and then essential workers, and then 70 to 79, and then oldest to youngest versus grouping all the 20s to 60s together. These things are not robustly differentiated in our model that you can't really tell, but what's very strong is the green bar higher than the other bars. So the age-based rollout is not the best rollout. A rollout that prioritizes preventing transmission is the best rollout. Okay, so your modelers, you're thinking, yeah, but what about, all right, so here's some of the whatabouts. What about the portion of contact among non-essential workers? What about the fraction of workers called essential? It turns out if you double that or halve that, you get the same result. The strategies, sure, you can make up lots and lots of these things and you get the same result. The vaccine efficacy, I haven't gone through too much here. I guess, was it here? Yes, efficacy against infection, 0.6, 0.75, 0.9. This does not change the message until it's 0.2 or 0.1, until it's much lower than are consistent with data. The underlying transmission parameterized by R, the rate of vaccination, it matters. If you can vaccinate everyone tomorrow, it doesn't matter whether you do essential workers at 8 a.m. or at 10 a.m. There's no time for transmission to happen between the groups. So rate of vaccination matters, but not within kind of realistic numbers for Canada. You can get this result in my age and contact structured model with a contact matrix and blah, blah. You can get it in a much simpler model. You can get it in a much more complicated model. You can get it if you resample the contact matrix elements with some normal independent resampling. That's where these error bars come from here. It just shows you how different, you know, you're not going to get purple bigger than green in any of this. Okay, when does it break down? It breaks down when everyone's going to get exposed anyway. But in Canada, I would say that's not relevant. It breaks down if we're willing to see 40 to 60,000 incident infections per day. Here in BC, we panic and turn things around when we get to about 1,000. In Quebec, I think it gets to about 3,000-ish cases per day. You would know better than me before they introduced curfews and lockdowns and things. You're not going to get to 80,000 incident infections per day. If you do, everyone's going to get exposed, and you're better off protecting the oldest first because you're not preventing enough transmission. But contextualize, so this result with R of 2.5, I think, or 2.6, was in the science paper by Bubar et al. And even with their lower R of 1.3, if you put them in context and you look at what we would be likely to do, we would not be likely to let a COVID pandemic go through our population at these levels. We've introduced control measures at a 20th to a 50th of these levels. And even here, when it starts to break down, actually putting essential workers earlier in the program does reduce hospitalizations. It's just that this is kind of the level where it starts to, you break the younger sooner is better here, you get more hospitalizations. But that's kind of much more than this, than you'd expect to just want to do a risk-based rollout only. Okay, I'll talk a little bit about these quality-adjusted life years. The main point I want to make here is, independent of efficacy against transmission and force of transmission, chronic impacts make a big difference, the pale green. They are not as important as deaths if you kind of wrap all these things together, but they're the next most important thing, and we should be aware that chronic impacts are something we need to look out for if we are going to let a lot of COVID roll through our population. We looked into herd immunity, what portion of the population is vaccinated or is vaccinated or naturally infected at the time at which cases turn around, like the so-called herd immunity point. And of course, ultimately, with high transmission, it won't matter that much the order of vaccination because many people get exposed anyway. But at low rates of transmission or effective reproduction number in the absence of vaccination, it actually makes quite a difference. And you can see that you get more effective use of your vaccines. You need to use fewer of them to get the cases to turn around than you do if you have an strict age-based rollout that we had planned in Canada. So the green line. In fact, you get about half as many vaccines being used. This is still under, maintaining quite a bit of social distancing, the 1.5. If we did that and cases turned around and then we thought, oh, it's good, they've turned around, let's reopen, then we would see more cases, of course. Okay, so we've tried to send this message. We've tried to communicate this in lots of ways. I've done quite a bit of media work on it. So have my co-authors. We've presented to the Ontario Science Table, and I think that was really effective. But one of the things we get in response is this, what I call the intuition model. Given the high fatality rate in the elderly, how could that ever be possible? How could delaying their vaccination, even those 3 weeks, ever be better for them? It can't be. It's because it's so against my intuition. All right, so I would say intuition is a model too. It's not a mathematical model, but it is a model. It is an understanding of how the world works that you use to reason with and make decisions. And it makes assumptions. And I think the underlying implicit assumptions in the intuition model are that everyone is equally likely to be exposed. Exposure rains down from the lottery or from God, and it rains down equally on everyone. And, related to that people don't infect each other. If exposure rained down randomly, independently, and your exposure was not connected to the exposure or vaccination of your friends and contacts, then this whole model wouldn't work, and we would need to just take the most at risk, find them however you want to find them, comorbidities and age, and go in that order. But these assumptions are both wrong. So intuitive models, when you do take that wrongness into account, that people infect each other, that vaccines can prevent infection, and that vaccines therefore shape who is exposed and how many people get exposed, then you find a different answer. Okay, so the intuition model. I'm going to finish with another model I call the cartoon model. And here it is. So these are my little folks here, and I've got a low transmission environment. So here's low transmission. The gray folks are the essential workers, and they do all the transmission in my cartoon model. And the blue ones are the elderly, the vulnerable, who we need to protect. And the red arrows are the path of the virus. Okay, now I'm going to roll out my vaccine. I'm going to do it 2 ways. First, I'm going to vaccinate 5. I've only got 5 doses. So I'm going to vaccinate 5 of my elderly people because they're the most important. And in doing that, I prevent 1, 2, 3 bad outcomes. These folks didn't get exposed, so they would have been fine all along. Okay, so that's model 1. And then in scenario 2, I have the same 5 vaccines. I'm going to vaccinate 5 of the essential workers. And whenever I've blocked a transmission event, I'm going to slash it out with a little yellow mark. So I've prevented this transmission event and these onward ones and so on. I've prevented, this one actually didn't do much. He wouldn't have been exposed anyway because I protected someone above the chain. And so I've protected these 5 essential workers, but I've got some good indirect protection here. I've protected 1, 2, 3, 4, 5, 6 indirectly. So I can just tally that up. Vaccinate the vulnerable, the first one, I've got 5 direct protections and I've prevented 3 cases. In the indirect mode, I've vaccinated 5 directly. I've prevented 6 cases in the vulnerable, and I've protected 11 people in total. So this one is clearly better in my iPad drawn cartoon model. Okay, when does it break down? Here's how it breaks down. Here's my high transmission, same people, same story. Actually, they're the same configuration and some of the same edges, but I've added more edges because now I have a virus that is more transmissible, much more, not just 40% more, it's at least sort of double. Okay, so I vaccinate my 5 vulnerable and I protect all of them because they all would have been exposed. Here I vaccinate my same 5 essential workers, but I have actually fewer yellow edges, or a smaller proportion of the red arrows are crossed off. And that's because there are multiple routes by which people can get exposed. So this person, for example, even though I vaccinated someone above them in the transmission chain, the virus is so infectious here, there was another route to this person, and I didn't protect downstream. I didn't protect these folks. So this kind of shows you in story form how the model works and why it works robustly in not only my age contact model, but lots of other people's models. So when I do my tally, if I vaccinate the vulnerable, I've prevented 5 cases, but if I vaccinate high contact, I only prevent 4. And that's because there are multiple routes to transmission of the virus. And so I'm not getting that huge indirect effect boost. There we go. I should say the CDC in the US recommends vaccinating essential workers early. I think realizing that, what we do when we do social distancing and we turn on and off all these measures, we are actually forcing our system to stay in this mode. We're not letting this rip through at a high transmission rate because we're shutting things down to always stay in this regime. We were delighted that BC announced vaccination of frontline high contact workers. I hope that this will stay despite the changes in the AstraZeneca rollout, but this was fantastic. Like I said, they asked us to do some of this work, and so we knew they were thinking about it, and we were delighted when they announced that they were going to proceed with it. I think it's a powerful tool. I don't think it'll get ahead of the B117. I think we're in for a rough few months, but I do think it's a powerful way to prevent this pandemic from being much worse than it needs to be. So some of the conclusions, long COVID matters. Bad things can happen to you that are not hospitalization and death. The fact that vaccines can prevent transmission is great news, and we should use it. We have few vaccines. We need to make the most effective use that we can. The fewer we have, the more important it is. There's no real trade-off because it protects everyone. So I would say, what's better than a vaccine in 6 weeks? A vaccine in 8 weeks, but much less exposure in those 8 weeks than you would have had in the 6 weeks. There's also an equity argument that's about the direct effect. Essential workers have borne the brunt of the pandemic. They often have low incomes, limited bargaining power. They have had COVID and variant types of COVID at much higher rates than others, and they can't elect to stay home. So I think there's an important case for the direct effect. I've mainly talked about the indirect effect. Okay, so thank you. I will stop there. Hope I haven't taken too much time. I can't see my computer's clock with your images here, but just to acknowledge these collaborators and thank you.
You're doing great. You have left lots of time for questions, and I'm sure there will be lots. Thank you so much for that very interesting talk. Carmen has a question already, and I see there are other people who have their hand raised, I guess, on Zoom. But Carmen, I'm not sure, do you want to ask this directly, or should I read it?
You can see the questions, Morgan. Do you want me to stop the share?
It's totally up to you. I'll read the question, and it's really up to you, because sometimes people like to go back in between. So she asked, if distancing lockdown is high, doesn't that shrink the susceptible population enough to imply the need to include competition between strains? I think this was maybe when you were when talking with Jessie as well, with the two models, but she can correct me if I'm wrong.
Yeah, so that's a really good point. And actually, I'll go back to that slide. It's this one. I'm really interested in competition and coexistence between pathogen strains, and it was one of the first topics I got into in infectious disease modeling, because it's a really interesting point. You know, of course, most of the population is susceptible, and I would not imagine that COVID is really competing for susceptible hosts, just based on that intuition, my intuition model. But you're right, as we shut things down more and more, in a way, we are depleting the number of susceptibles that a virus has access to, even though they're out there. If they're all sitting at home in their laptops, they're not, as accessible. So I think it would be interesting to develop ways to measure whether the viruses are really competing for susceptible hosts or not. And we do have a version of this now that has one susceptible population at the top, and then the two strains or variants, a higher transmission, variant of concern, all of them together, pool and a non-pool. And we could see if there are differences in the predictions. I don't think there would be, because I think this is still basically just independent exponential growth. Also, they're not always in the same exact outbreak or the same exact place. So there's some stochasticity there, but I think it's a great question. And yeah, maybe it's not fair to blithely say, hey, we know they're not competing because most Canadians are susceptible. That's not the whole story.
Right. Yeah. I think, yeah, especially like you mentioned, that there might be locality, right? Like you have a tighter contact network in like Whistler, for example, than you might have in all of between Quebec and Vancouver right now.
Yeah,
not to point out Whistler against anything. Sorry.
Yeah, apologies to the rest of Canada if we have sent home a bunch of people who worked in Whistler and have now diaspora out to the rest of the country with their.
But we probably shouldn't have been there, right? So we can. Everyone's saying sorry. Jacques Belair has his hand up. I don't know if he wants to unmute.
Yes, after hearing this talk a few times now, I understand.
Sorry.
About curfew, the distinct strategy in Quebec to having a curfew in. This will show up in the contact matrix, right? So this will be like a piecewise constant contact matrix, because you average and then you contact, right? Over time.
Yeah, so you mean in terms of daily, there would be this jump? Yeah. The day-long time scale is not something we've really thought about.
So this would probably be not the good approach to put curfew in and see what's the effect, because there seems to be limited data on the effect of curfew, even in France, where it's been in effect for a number of months.
Yeah, I think it would be, if I wanted to know the effect of curfew, what I would really want is kind of community outbreak data that had much more detail around, maybe genomes that could help you try to unpack who infected whom and when, and contact tracing. And I would want that from some outbreaks during the curfew and not during the curfew. I would imagine that curfew, if it works, it works because people can't socialize in the evening, and so they socialize less overall.
Yeah,
If what
yeah,
they do is they pack their contacts all in before 8 p.m. all together in one room of 500 people, and then they all rush home at 8 p.m., then of course this is not the point. But I imagine that, you know, it would reduce the overall contact, and that's what we would see. But pinning down those differences, it's hard to imagine the kind of data you would need to get it, but it's definitely not data that's publicly available to me. Maybe you might be able to get some from Quebec.
No, because what I saw was data from France and also from Guyana, and it's very inconclusive. I mean, when the curfew is stronger, the decrease was a bit steeper, but it had started before the curfew. So it must be specific to the region contact structure. That was my impression.
Yeah, that would make sense. And that kind of data, if you had curfews in lots of places and they had really different impacts, you know, that was
But I've not seen that yet.
I would note that Morgan told me there would not be a lot of overlap between this talk and the Fields talk that I just gave that was very similar. So I think if I'd known, I might have we've done some vaccine.
No, but this
at the end modeling I would have put in, but
no, I could see sufficiently many differences to see it was not the same, and it was not a videotape.
There you go.
So
thank you.
Just blamed you there, Morgan.
No, that's okay. No worries. It would be my fault. Is there anyone else with another question? Oh, there's a question in the chat. You mentioned that the B117, but not the P1. What about this variant, which appears to be 2 to 2.5 times more infectious versus 1.4 times for the UK one, and possibly a high likelihood of reinfection of individuals? Any thoughts?
Yep, that is the thing that keeps me up at night. I think that's absolutely right. When we did this modeling, we had data for B117 from the UK where they, because of the PCR test they were using and this phenomenon of the S gene dropout, they actually knew for most of the cases they'd had from September to December whether that individual had a B117 or not. It's more complicated, but that's approximately right. And because of that, there were really good estimates for how B117 really swept through the population, not just in one age group in one place because that age group had a bad luck founder effect, but really across many jurisdictions, very consistently, not one age group, not one community. So that was the one we knew about. We were worried about P1. We didn't have it yet in BC. That was a few weeks ago when the world was a nicer place. And the data on transmissibility, I would say, were not as strong. You're right. The Manaus experience in Brazil, where they had a huge first wave, where some modeling paper estimated 45 to 66% or 44 to 66% of the population had COVID. At the same time, there were mathematicians saying, oh, contact is so uneven that herd immunity, you're only going to need 20% because you're going to get into the most high-risk people, and then it's going to be done. People were really optimistic, and then, sure, P1 caused a huge another round of infections. Looks like it can infect people who have already had COVID. Our models assume permanent immunity, permanent and perfect immunity, and even so, they still look bad with variants. So, I think there's been some wishful thinking in public health. It's odd to me, the idea of a risk in health, because we are vaccinating as our main tool to get out of this. I hope we're not imagining in public health that we're going to continue distancing measures for the rest of time. There's been a lot said about how damaging it is, about schools needing to close, about the economy, about food insecurity, about housing insecurity, about young people, about universities, about all of these things. And yet we are relying on vaccination. We have let new variants, almost a new pandemic, arrive on our shores since January and establish itself or themselves, where we don't know the impact, we don't know the effectiveness of the vaccines we're giving people against the variants that we are hosting and allowing to spread. And I am a little mystified at why we are doing this. And I am worried about those, even if it's not 2.5 times, even if it's only 40 or 50% higher, so we did some modeling. Maybe I'll stop the share and I'll pull it up because I can show you. This is a report that I wrote with colleagues yesterday. Well, I finished it yesterday, so this is like really hot off the presses. We're doing this same modeling, and we're looking at, okay, I'll share this. This is going to be a not very professional, like straight from the overleaf, I didn't make slides kind of share. Okay, what happens at the end? What happens if we vaccinate and we reopen? If we reopen to R is 2.5, even after our current rollout, we still see a large bump of infections and hospitalizations above what PHAC thinks the capacity is, about 30 per 100K. I don't know if that's right. No idea what the hospital capacity is, but it's still a bump. And you get a lot of infections in the 10 to 19 age group that we haven't vaccinated. So we're not really robust to an R is 2.5. If we have, and that's what R would be, I think, for B117, if we keep up like perfect, awesome, infinitely extensible symptomatic testing and contact tracing, and we wear some masks and we wash our hands and we spray some stuff and we do some things. That's what this would look like. If we had something that was even more transmissible than that, this would look, guess what, worse. Okay, so then who gets infected, we looked at that. The people who declined the vaccine, and then who gets hospitalized, also the people who declined the vaccine, but older ones, because their risk is higher. This would probably drive people to go get the vaccine once this happened. They would hopefully think, oh my God, the hospitals are filling up with people who declined the vaccine. Maybe I should change my mind about that. Let's hope that would get hesitancy down. We're advocating here for vaccinating kids. Turns out it makes a huge difference. But I want to answer your question about P1, so we'll go back to here. This is, what happens if we have a variant where the overall efficacy is still good. So we still have an almost 90% efficacy against symptomatic disease, but only 50% against infection. And that's reflects, I think, the evolution the virus is facing. The virus has not yet bumped up against vaccinated populations much. And P1 has, of course, bumped up against naturally immunized populations who had infection. Anyway, this is what it looks like. It looks bad. This is, we open at still 2.5. So not even with the transmissibility of P1, optimistic, permanent immunity, but just the vaccine is less effective because against transmission and still good against symptomatic disease. We still exceed our hospital capacity by a factor of 3. We still have large numbers of hospitalized individuals. This is even with vaccinating kids, which makes a big difference without the VOC. Okay, so I will stop there with this overleaf document, but yeah, it's not good. And that's, P1 is the thing keeping me up at night. I have reached acceptance after the 5 stages with B117. We did not stop that. We're not going to stop that. It's here.
Yeah. I think that also, when you're showing those results, brought up something for me that actually I think is related to the next question, which is that, obviously we're talking about in the Canadian context right now, but this is a global pandemic, and we're talking about vaccination strategies for our context, as you were mentioning, but there is, like Julien Arinaud's work, there's a huge contact network of people across countries, and so the end of the wave is actually quite related. So maybe we have one more question, and then we're past time, so maybe we'll make this the last one. While there are some policies for testing new arrivals or people newly arriving via land and airport, would you say that vaccination of also these people would be a priority, and would it make sense to be included in the model in curbing transmissibility, especially of new variants, given that there are many variables such as individuals who are not conforming with the policies in place?
Yeah, that's a good and complicated question, and I should sort out my thinking on border measures. It's complicated because if you have lots of community transmission, almost all the cases you're seeing will have been acquired locally, and the impact of border measures is kind of linear. You have kind of a linear introduction and then exponential growth. If you're really doing great containment, then those introductions sort of don't matter because you're going to contain them all. I mean, they matter. You're going to contain them all. Border measures are the most important if you're doing an Atlantic bubble or a New Zealand approach, where you know that your inherent R is going to be much bigger than 1 because you're reopening and you're relying on not introducing the bug to as your main way of, or one of your mainstays of control. Then it's incredibly important. So I think what vaccination would do, I guess, if someone already has a negative test, you know they're not exposed, and you can vaccinate them as they come in if they're not vaccinated. Yeah, I mean, if Bermuda started doing that, I would fly there. Like, I think this is like, what a great way to get people. It probably would not prevent introductions, because vaccinating them at the border won't cure them if they're already exposed. And if you're testing them and they're not already exposed, then they're not exposed. I do think that could have a benefit. For example, we need agricultural workers to come to Canada. We don't have the skills and resources to do that work. And having them vaccinated will protect them and will protect the communities around them. So in that kind of case where people are coming to be in a congregate setting, that might be the most powerful. But yeah, it's a complicated question.
Right. Yeah. And also, if you think about people, maybe not essential workers, who have to quarantine for 2 weeks, and then you're thinking about, the effectiveness of a vaccine over 2 weeks, it kind of coincides. So it might be an interesting policy. Well, with that, thank you so much. This was a great talk, and I think everyone would echo that they're quite interested, and it was very fascinating. So thanks again for joining us, and good luck. And we look forward to hearing your next results, which all have been very interesting.
Thank you. Thanks so much for having me and for your great questions. Sorry to have gone a bit over.
Oh, no worries. Great. We'll see you soon, Colijn.
All right. Thanks.
Bye, everyone.
Bye, everyone.